This first presentation is a joint presentation between myself and Dr. Evonne Curran, and I'm going to provide some introductory slides to the main part of the presentation, which is really around the critical thinking analysis around modes of transmission and how we need to think differently about how infection is spread. But how did we get to this presentation today? And how did we all get to where we are, with a lot of us involved in work still around the pandemic and pandemic learning? Well, yesterday, for those of you that were here, the theme was very much around learning and reflection, and how we can use that to put into practice in our roles at the local level, potentially at the regional level, and feeding up into thinking and actions at the national level. And that theme continues today. And it's also timely, as I'm going to be presenting on sustainability at the end of the day, that actually all of this is in the context of a constantly evolving work. So some of you, if you look at the news, if you can bear to look at the news, will have seen that the Climate Change Committee issued its report with some very stark warnings and recommendations that will ultimately impact on your role, the delivery of health and care, and anything that affects health ultimately affects the prevention of infection. So we live in a constantly evolving world. Reflection, learning, critiquing, critical thinking has to be part of our everyday practice, not just something that happens after a major event. So the pandemic was predicted. Many of us attended numerous pandemic preparedness sessions. It evolved, and its legacy remains very real and current to this day. Yesterday I presented on the COVID inquiry. This was is the largest inquiry ever commissioned by any government. It's absolutely huge, and it's really, really important. Yesterday I talked about its purpose, its structure, its powers and processes, which are all in place to enable learning and to make recommendations to support us to prepare for future events, and also make sure that we are resilient to the impact of future incidents. So now really is a unique, and I would say a seminal moment in time to reflect and identify learning. Many of you in the audience are nurses, and as nurses we are critical thinkers. We use that skill every day, but that is not the same as criticism. Being a critical thinker actually is a core element of nursing practice, and as the largest proportion of the healthcare professional workforce, it's a very powerful skill to have. So what themes have been identified so far from the pandemic and from other learning that's taken place? If you haven't read some of the evidence statements associated with the pandemic, I would urge you to go through and choose those that are most relevant or of most interest to you. But one of the ones that I continue to use a lot is the statement of Professor Clive Beggs, who's based at Cambridge. And one of the key elements of his statement around how some of the language and some of the assumptions that were made drove certain decisions in the pandemic was around this assumption based on the limitations of historical research into droplet versus aerosol transmission. And Evonne is going to pick up in more detail on this. And that's an acknowledgement about how we have thought historically. But what we have to do now is to enable ourselves to think differently and think critically about what we're talking about. There's absolutely an aspect of limitations of rigid categories in the classification of infection pathways, and what could be described as one-word transmission dynamics. It's actually more complicated than that. We cannot reduce everything to one or two words. It's not a criticism, but there is limited experience amongst infection control teams, naturally, of experience in dealing with large-scale incidents. So we need to support teams at the local level, the regional level, and the national level to be more prepared in the future. And with the constant change in structures and systems and restructuring of organisations, there are real risks, and we know what those risks are. They're very real, of the loss of historical memory and experience in dealing with incidents. For as long as I've been working in infection control, there's been a sort of acceptance, and nurses still talk to me about this, that actually getting an infection whilst being a nurse is an occupational hazard. It comes with being a nurse, and actually we really need to start challenging that. Not just because of COVID, but actually because of the wider implications for the spread of infection and the implications for the workforce and the colleagues that we work for. There's a significant lag in terms of how evidence evolves. And this is much slower than actually changes in clinical practice. So we've got to think differently about how we write guidelines and keep them up to date and engage those stakeholders that are the ones that are implementing it in practice that is evolving so fast. The power of opinion and social media. In the swine flu pandemic of 2009, we didn't have the amount of social media that we have these days. So that's something that we're going to have to cope with in future, and this sort of information, infodemic, as it's called. And then how we evolve as professionals in the culture of health and care organisations. So that's just some of the themes that have been identified so far. So why is it critical now to address air? Because air has always been there. Well, essentially, to summarise it very succinctly, if we get the mode or modes of transmission wrong, we put in place or advise the wrong precautions, and ultimately we then fail to prevent infections. Now, air is not new. In my over 20 years now of experience in infection prevention and control, I've certainly had experience in dealing with issues associated with the air, and I'm sure that many of you have as well. And I've just put a couple of examples up here based on my personal experience. The first, actually quite early on in my IPC career, involved an outbreak of MRSA when we had a patient heavily colonised with MRSA in a ward in the summer. Fans were distributed to help patient comfort, and every patient downwind of that particular patient got MRSA. So the role of airflow within ward environments is well recognised, and that's not an isolated incident. Many of you, I'm sure, will have had experience of that. The second was quite interesting and very early on, again, when working with some of the authorised engineers and people in operating theatres, became very aware, because of the impact on surgical site infections, about how forced air warming blankets were disrupting air circulation in operating theatres that was ultimately having an impact on surgical site infections. And that is documented. It's not a randomised control trial, but it is absolutely documented in the evidence. And then, again, because of the design of the hospital that I was working in at the time, with a racetrack system of 4 wards and the way the ventilation worked, dealing with multiple outbreaks of MRSA in our orthopaedic ward, which is a clean ward, patients screened coming in, absolutely stringent hygiene measures. Actually, we weren't able to control MRSA outbreaks because the air intake from the emergency ward, or on the other side of the racetrack, all the air ended up being dumped in the orthopaedic ward. So that's another example of the importance of air and thinking critically. So the lesson that I've learned over time has always been to expect the unexpected. And that's based on my learning and experience. Actually, it's about evolution and how things change. Nothing ever stays the same in healthcare or infection prevention and control, but the principles remain the same. Constant changes in clinical practice, changes to our population through demographic changes and migration and vulnerabilities, and then increasingly, as I'll describe later, the effect of a warming planet. So 2 examples here, just to demonstrate how things have changed over time. There was a time when we thought PCP could not be transmitted between people until it was identified that that was actually possible. And then as recently as 1975, so some of the oldies like me, you will not think it was that long ago, actually that Clostridium difficile was identified as a cause of antibiotic-associated diarrhea and pseudomembranous colitis. So learning happens all the time and changes our practice. So before I hand over to Evonne, I just wanted to put this slide up because for me, it's a significant time of reflection about all sorts of things, but in particular, what is infection prevention and control and what is the role of infection prevention and control specialists. And this is the definition from WHO, which remains current on the WHO website. It's a definition that I've used for years, but increasingly I am questioning what is an avoidable infection. Are we really working to that definition for whatever reason? What is preventing us from working to that definition? But what does remain clear is that IPC is unique in the field of patient safety. If you were at Yetta's talk yesterday, she spoke very eloquently about the patient behind the data. So these are patients, they're real. We shouldn't normalize data and numbers. There are very real people that are impacted by infections, whether they are avoidable or not, but our role is around avoidable. What does that mean? And what does that mean today? So defective infection prevention and control, not intentionally, but it can cause harm and it can kill. So with that, Evonne, I'm going to hand over to you.
We're looking at why this is critical or a critical problem. So I'm going to do a little bit about where we are now. I'm going to do source to infection pathways, which might be a new way or a better way to describe transmission. And I'm going to look at what is the infection prevention priority now. I don't think infection prevention is something that is static and applies to, or the primary cause applies to one unit. I'll explain that a bit better in a while. I was told that you shouldn't start a presentation with a quote, but I'm going to hang that. So this is from Adam Grant, who wrote a great book called Think Again. And he said, this is actually from an article, not the book, but it's very worthwhile to note. When people don't stand up to bad leadership, it's rarely because they don't care. It's often because they feel powerless. The answer is not to accept defeat. It's to find new avenues for influence. And for somebody who's had no avenues of influence with regard to the pandemic, it was a very helpful one. And thinking through this presentation has also been helpful. So where are we now? Well, we are in April 2025. But in August 2024, those people that write the National Infection Prevention and Control Manual for Scotland redid their literature review. And they said, what we have said before in the 2020 literature review that took everyone through the pandemic, i.e. that's the droplet-airborne dichotomy, was clearly inadequate. And that was not just for, in general, it was also specifically for aerosol generating procedures. So what they said about respiratory transmission was clearly inadequate. Now for England, they don't have their own literature reviews. They have a button there which refers you to Scotland. So what we are now, or where we are now, is that both National Infection Prevention and Control Manuals say that droplet transmissionless AGPs, whilst the literature, the up-to-date literature, says that's clearly inadequate. So they know it's wrong, they've accepted it's wrong, they've printed it's wrong, and nothing's changed. Now, pathogens always were, and always will be, in the air. And we owe that to Lord Lister, Essex boy. He might have invented antiseptics in Glasgow, but Essex boy. And he said it's when you make incisions and you open up these sterile areas of the body, the organisms in the air fall in and they suppurate and cause infection. So he never stopped developing his antiseptic system. He had spray guns, he had putty, anything that you could put antiseptic in, he put it in. And he dropped a 45% mortality rate to 15. But on came Bergman and said, yeah, your antiseptics are good, but we're going the whole hog. We want a sterile system. We want an aseptic system. And that was introduced and worked even better. Along came anaesthetics, and the surgeons went, well, hey, we're not just chopping off bits of dead legs now. We can go anywhere. But still, they were getting infections, and lots of mechanistic research, i.e., how does this happen, was done. And it again showed that it was in the theatre where incisions were made and sterile areas of the body were opened, the pathogens came in from the air, disseminated from the people in the room. That's how you get a surgical site infection. They fell into the wounds. Now, here's an old outbreak. This happened in 1968, 1969. It happened in Curran. Now, this was a war hospital. These were built in 1940. It was built to get away from what would be the Blitz in Glasgow, a big shipping area. So they built this thing, that's 8 wards, there was another 8. But it housed the neurosurgical unit for all of the west of Scotland. So, I don't have a print here. So that's what it looked like. So they had a massive outbreak of antibiotic-resistant Klebsiella. The doctors thought it was going via the tracheobronchitis people, and I think they're right. 28% had an upper respiratory tract infection, 20% had Klebsiella in their urine. 8 people got meningitis and died, and most of these had a CSF leak. 3 patients died in pneumonia. But the surgical site infection rate, 1.7%. Now, that was all down to that bit there. The hospital is now abandoned. It was a mecca for people taking photographs. This is a theatre, state-of-the-art, 1970. Now, what makes it state-of-the-art is that. That's downward displacement ventilation. And what downward displacement ventilation does is it takes air, or forces air through, I've got an engineer over there who's going to tell me if I'm wrong, forces air through, and all of the organisms that are disseminated from skin from the people in the room, it takes them out there. And this bit here, this is the nurses saying, yeah, we understand the air will be disturbed if we walk in and walk out of your theatre. So you drop an instrument, we'll hand you a clean one through there. So that's how that infection rate for surgical sites was so low. Now, not only did we improve ventilation in theatres, we went from a design like this, which was the design of the Curran Hospital 12-bedded intensive care unit. We went to compartmentalised wards, first called for in 1849. That's another story. We went for better ventilation, and we went for wash-hand basins as well. But we also, something Rose mentioned, we recognised that some people disperse vastly more organisms than others. And in particular, we can think about burns patients. Burns patients are very vulnerable to infection, but once they get infected, they disseminate vast quantities, and they were quite often the source of outbreaks in days gone by. So these went to specialist units. And we did some other bits and bobs as well to help us along. The main thing is whatever the infection prevention priority was identified as, and it changed, it was tackled. It wasn't eliminated, but it was tackled. And prevention priorities continuously change. So until 2009, airborne dissemination was a thing. We believed it, we taught it. The air was considered a pea soup of airborne particles, many carrying pathogens. And here we see some staphylococci sitting on a skin scale. Here is the first guidance, I think, on infection control, 1944. And what it's telling us there is there were dust-borne infections. That's how they classified them. And that this research, 1937, there are certain times in the day and certain procedures which disseminate bursts of pathogens, sweeping, bed making, dressings. So the air quality changes over time. The number of organisms in the air changed. So what happened in 2009? In 2009, in an attempt to do good, we refocused. And instead of having a broad church of it's in the air and it's contact, we went, no, it's contact. And I think the WHO got that wrong. WHO is trying to write a document for every care setting in the planet Earth and saying it's always hand hygiene. That cannot be the case. So as Rosa said, one-word descriptors to define a source to infection pathway appear inadequate. There's lots of pathogens that go through the air without causing respiratory infections. Streps, staphs, noro. Yes, noro. Now this was the modes of transmissions as defined in both NIPCMs at the start of the pandemic. And what we can see over there is airborne dissemination has been airbrushed. Somebody says, I think one line is, don't shake the linen. It's not enough. We've got our contacts, and then we had our two modes of respiratory transmission, and as has been described by aerosol scientists, that defies physics. I don't think it's a bigger insult that you can have as an infection prevention and control if your mode of transmission, how you are saying pathogens spread about the place, defies physics. And I think the argument should not have been about airborne or droplet. They both travel via the air, albeit subject to different physical forces. The argument should have been about how they enter to infect. So, source to infection pathway. Now, there's always a couple of weird ones. Someone will bring something in contaminated. It happens, it's very rare. By and large, your two sources of pathogens to cause HCAI are people and now the environment. The modes of transmission now, this is how it gets from a source to an entry point. We've got airborne dispersal and contact transfer. And you can get redispersal as well. The other route we've got up there is translocation. And we have to think of airborne dispersal and contact transfer as a taxi service. They're your Ubers. They're always available. Now, the other thing is about the bursty process. I said bursty process before, that these bed-making dressings release pathogens in bursts. But there's lots more that we maybe don't think about release in bursts. Knock a hammer against a brick wall and you'll have some aspergilli floating about. Coughing, we've said bed-making, sweeping floors, infectious diarrhea, pulling the chain, right? We can actually think about biofilm, because biofilm is on catheters and biofilm is on plumbing, which I think we might hear about. And when bits slough off, we can think of that as a bursty process too. Incision and drainage, contaminated splash from sinks, dressings, etc. Okay, now this is not Evonne making it up about bursts. You've got another 1975 paper, just like Rose had. This is talking about mechanistic evidence. They were trying to find out where are these pathogens coming from, how are they going, and they identified similar bursts of dispersal were also characteristic of the situation in Greenwich, right? So we have got our source, we've got our mode of transmission, and we've got entry points. Whenever it gets to an entry point, it's not a problem. And then we've got our ways that it gets in to infect. It can be inhaled, it can be aspirated, it can be ingested, invaded. We can infuse it in, or we can transplant it or transfuse it in. There are our transmissions. Now, once we've got this, we can say, right, okay, how does this infection happen? So how does non-ventilator-associated pneumonia happen? Now, I've dark greened them when they are the dominant route. There's only one route here. The organisms are already up here. They're already here. And they are micro-aspirated. They translocate, and then they are micro-aspirated. What do we do about that? We position the patient, mouth care matters, good basic care. We cannot eliminate all pneumonias. What we can do is give the patient the best opportunity to not develop one. What about ventilator-associated pneumonia? Well, also translocation, also microaspiration, but you can get biofilm forming on the ET tube. It can be down the lumen or it can be on the external. So it can be biofilm and then it can be microaspirated. We could use a dirty laryngoscope, we could use a dirty ET tube. I doubt that we would do that. But it can still happen that way. What do we do to prevent it? Well, whatever the Intensive Care Society tells us to do, because quite honestly, they're on the ball on this one. Now, tuberculosis, and don't dismiss TB. I've never seen any TB-acquired nosocomially. I have, and there's quite a few of it about. Now, it can translocate. We know you can get TB in the brain, in the bones, spleen, various places. But it's airborne. Somebody's got to breathe it out, and you've got to breathe it in. I'm talking nosocoma. We're not going into cows and what have you. So somebody's got to breathe it out, and somebody's got to breathe it in. We are inhaling this. Now, you can also get, I had 2 or 3 of these. You swallow the sputum and you find it in a stool. So we have to think about ways that we find out that it's TB too. But what are we going to do about TB? Well, we have to remember the bursty processes for TB. There are good papers in the literature about bronchoscopy, whole genome sequencing, doing it. Post-mortem, I know too many. I know of too many post-mortem doctors. Well, I'm married to one, but he hasn't got TB. But if you make an incision in a TB lung and you weren't expecting TB, the warmth, bursty process of TB is enough. And so a couple of lovely papers in the literature about incision and drainage of a TB abscess and those people getting it. What do? We find them, we treat them, airborne precautions, and a negative pressure room. If you get it, you're 6 months on antibiotics. If you get drug resistant, good luck. Right, surgical site infection. I already said it can come from the person who's being operated on. It comes by airborne dispersal and contact. Why don't they open up all their packs before they operate? They open them up immediately before, because airborne contamination will land on the instruments and contaminate them. You're going to get to broken skin, and they're going to invade after translocation as well. We do lots about this, but we have got to the point, and I've seen it written in a paper recently, we forgot that theatre ventilation is working in the background, preventing surgical site infections. It's there, doing that. The number of people in theatre will increase the risk of airborne dissemination of pathogens. We need sterile instruments, skin antiseptic, all of the stuff that we do to prevent surgical site infection. Okay, primary bloodstream infection, these are your catheters. The skin organisms are already there. But we can get airborne dispersal from within a ward and from the patient themselves. We can get contact transfer if we touch dirty parts of, or we touch and make special pieces of equipment unsterile. The hub is very important, because if we don't decontaminate the hub, we're going to infuse them straight through. The hub will be contaminated, no question. So what do? We have sterile instruments. We have aseptic pre-access and connections, and aseptic insertion and maintenance. You'll notice gloves is not up there, and that wasn't just for Rose. Infusate-related bloodstream infection. This is where we contaminate the drug, right? This is the ones where they've taken water out of some ICUs, and oh, look, all these gram-negatives are going away. So infusate-related can be splashed from the tap with bits of biofilm floating off to where people are making IV infusions. It can be if we use contaminated vials. It's unlikely, but reusing vials was a great way to cause, bad way to cause infusate-related infections. Now, what do we do about it? We don't make up IVs in a splash zone. If you don't know where your splash zones are, go look on the floor. Non-touch technique, no hang times, single-use vials. I did my doctorate on this, and I nearly fell off my chair with this. 1 million organisms per mil is invisible to the naked eye. So if you look at holding up a vial and it's clear, it doesn't mean you haven't got 1 million organisms per mil. Okay, Corti, well, they're coming from the patient's own perineum. And we have to avoid catheters where possible, do excellent catheter care, but the organisms are down there. Now, I did one of my first outbreaks with 3 patients with the same resistant organism, and I think it was the 12 o'clock catheter empty and bag time rounds. It was 1 jug, we've seen it. So it can go from the tap up, but it's much more likely to be translocated. So what about norovirus? Well, norovirus is on the move. We thought it was contact. Everyone was telling us it was contact. Turns out it's in the air. Now, we've always known that when you vomit, maybe 2014, it goes 3 meters that way and 2.5 meters that way. It doesn't all fall. Some of it stays floating in the air. So we've got airborne dispersal in there, and obviously we've got contact as well. And there is now this role of what needs to have a proper name, because it's got an Evonne name at the minute, which is sniff swallow. And that might be the way that we do. Think of it, they're in the air. Sniff swallow. We sniff swallow all the time. So what we're going to do, we're going to isolate cases, hand washing. We could give them their own toilet. If you've got an air cleaning left over, I would stick one in the toilet. I would stick one in the ward. I would certainly mask, because I do not want to vomit 3 meters in that direction and 2 meters in that direction. We can't put lids on toilets because we haven't got them. We don't actually know lids on toilets would work. What we do know is it's going up in the air from the toilets. Now, here is one of the papers that's telling us it's airborne, and they measured the air. How many virons do you need to get norovirus? 10. There were 5 to 215 copies per meter cubed. And this other one, fascinating work with how far a plume goes and how quickly it goes. A lot fall down to the floor. A lot of them stay in the air. You know when someone tells you at a party, I wouldn't go in there? Twice. Open the window. Okay, so let's do SARS. I'm going to say at the beginning, if you've got long COVID, you're no longer eligible to give blood. And that's because you get persistence viral in your bloodstream. That's not good. Translocation is obviously there because somehow it's getting into the brain and it's getting into all the other organs, and it affects once it's in. But it's airborne dispersal. Somebody's breathing it out and somebody's breathing it in. And so it's inhalation. We know it gets in the gut because it does damage to the gut. Is that a sniff swallow? I don't know. And contact transfer, the last time that was mentioned, it was about 10,000 to 1. It's the air. Right? So we need to clean the air. And we'll come on to these other things in a minute. But this is what you should do if you think you've got cases. Now, what I've done here is taken the HAI ECDC 2022 to 2023 point prevalence survey, and all of the categories of infection that I've given you make up 86% of all of their HAIs. In none of them is hand hygiene number 1. So how can hand hygiene be the single most important means to prevent HCAI? Can't be. Is it important? Absolutely. It's just not number 1. Okay. Now, if you look, you will find, when you look in the air, that these pathogens that are causing challenging problems are being found in the air. When we found them on surfaces, it's because we only looked on surfaces. But now people are looking in the air, they're in the air. So the air is back on the table. So, where are we now? We've got NIPCMs using a clearly inadequate dichotomy. We've got aerosol generating procedures that generate no more aerosols than a cough. We've got an under-recognised taxi service, which is airborne dispersal. And I think we've got an under-recognised need for indoor air quality. And that's both measurement and cleaning. So here's the question. Is prevention of airborne respiratory infections of value to you and your patients now? And the answer to that is yes, in the short and long term. You will notice this question was not, do you want to go to work in a mask? So here's another picture of Semmelweis. The story that gets told by hand hygiene people is kind of wrong. I wish I had a pointer here. So he starts work at one of those first 3 red arrows over there. And he introduces his hand hygiene because he knows he's got a problem. This is the mortality rate for women coming in, giving birth. It gets as high as 30%, but quite often running around 15%. 15% of women coming in to give birth get infection, die, as does their baby. So he introduces a disinfectant hand hygiene solution. He doesn't introduce hand washing with soap and water. That was already there. he introduced a disinfectant hand washing, and it was harmful to healthcare workers. You had to apply the disinfectant for 5 minutes till the skin was slippy, and it caused burns. Now, why he needed this is because his doctors went to the mortuary and touched dead bodies and dead tissues infected with group A strep before they went in to do pervaginal examinations. My surprise is, why was it only 15 to 30%? Okay, so the control measure he chose was intolerable in the long term, and we need control measures like what we have in theatre, which are tolerable in the long term. Now, he's not up on his literature either, because in 1843, 4 years before he started work, Oliver Wendell Holmes in America reviewed all puerperal sepsis and erysipelas. Now, these were common as muck. In my IPC career, I saw 1 erysipelas and 1 puerperal fever. But here we are. He said, from all the studies that he looked at, and I've read all his work, it's amazing, do not go to the PM room and attend women in labour. That was a tolerable control measure. So that's a very important point. Now here we go to Wales. I love Wales. They still count. God bless them. The number of inpatients with COVID, 149. The number of community-acquired cases, 11. The number of hospital-acquired cases, 111. That's in a week. So here's our 11 coming through the door, and that's what it's doing. Now, if we add in the indeterminate, we get even more. This is not acceptable infection prevention and control. A week later, only 6 of them came through the door with it, 128. This is nonsense. England data, they don't count as much, but I don't think you're any better than Wales. Got an average daily admissions of 144. This is like passive smoking being recognised as causing cancer. It's not the disease it was, but it's not nothing. The average bed occupancy per week is 8,000 plus. This isn't a trough. The next wave is coming. It's not gone away. Now, if Res Streeton said, I'm going to give you 9,000 beds per week, I'd make him a cup of tea. That's excellent. There are 9,000 beds here. We're waiting for him. Now, what is it now? It's not what it was when our ITUs were full. What is it now? And this is excellent work. I think it's published in Nature, 2023. It's a vascular disease. The damage you're seeing in lungs is a vascular disease. But it causes immune dysregulation. That means it makes us weaker to infections. So as a population, we're weaker. Now, if that's true, we should see it in the data. So here is the average sickness for NHS workers before and after the pandemic. I'm not going to show you where the pandemic started. You can work it out. But pre-pandemic was 4.22, and after the pandemic it's 5.7. So sickness amongst healthcare workers has gone up 20%. That's current data. This is not sustainable. The number of people who are unworking because they're ill health, it's gone up 33%. 21,000 children have debilitating long COVID. Not just long COVID, debilitating long COVID. And this is school attendance. The plan is to make people attend more. This is sickness. We have to do something about this. I was in infection control, actively working for 37 years. I never met a quademic. What the hell's a quademic? Over here, we've got some norovirus data. So you've got the line, that's the 5-year average. You've got the shaded line, that's the, I think that's the confidence interval, yeah. Look where we were this year. Flu deaths in Scotland hit a 4 to 5 year high. Flu deaths. You might remember all that hepatitis of unknown origin in children. And yes, we think it's maybe the lockdowns did it. Maybe it was adenovirus. No, it was COVID. Papers are out. This trying to pretend it's not COVID is not doing us any favours. Now, if you put in brain damage, COVID, and images, you get links to scientific papers that will scare the heck out of you. It's not the flu. So where I think we are now is a risky place. And you can't get from a risky place to where you want to be. Where we want to be is where we are with theatre ventilation. I'm not even worried about it. I don't even look it up. But you can't get there in one move. So what's the priority now? Well, it's not wash your hands. It's the air. And I swithered with this because it might actually be the information. It might actually be that we need a true and honest situation awareness. What the heck is going on with this virus now? And we don't have that. We have it's over. Hide that data. And there's two questions for you. How bad is the air in there and how long are you going to be there? Measure the CO2. Well, the CO2 in here, in a full room, is actually better than it was in Rob's car this morning. So we're doing okay. Where and when is it worst? And there are places when it's worst, but we only identify those by thoroughly investigating transmission in hospitals. We have vulnerable patients, way more vulnerable than us, and we're not giving a hoot for them. So what's the community situation? Because that might change what you do. Meet your engineers, one over there, nice guy, and he did great during the pandemic. What are your options? What can we do here? Where are we bad? So here's an interesting paper. 70% of household transmission starts with a paediatric case. Now, if that's true, then school ventilation is our #1 priority. Paper out this morning saying air filters put in schools. It was in Nature. I retweeted it. What was it going to 10% down with their air filters. I don't know how good their air filters were. Here's another study from China on schools, and it's saying actually far afield transmission, much bigger than we thought it was. So we have to reduce community transmission. We have to meet in places. Don't go in a cupboard. I'm sorry, there's no ventilation in here. I'll come in when you open the window and the CO2 down. We need to have cognizance of waste coming. We need to identify, isolate, and indoor air quality when we know we have got people with this virus. Again, how bad is the air in there? Oh, this was a nice one, came up very recently. Moreover, air viral load in the COVID room with an air cleaner showed a reduction of up to 98%. I'll have some of that. What are we doing? We're not investigating this. It's not like it was before, so it's okay. It's not okay. If you want to wait until you have got long COVID yourself, well, there's 0 treatment options, and you'll be likely diagnosed with a psychiatric condition. What we've got at the minute is availability bias. We are passively smoking, we're building houses with asbestos, we're not wearing our seatbelts, and we're using Marie Curie to define personal protective equipment for radiation. 3 realities. It's in the air. RPE is needed, not for non-aerosol generalized procedures. If you are close to somebody who is infectious for a period of time, your risk is through the roof. And RPE is obviously more effective. If you hear no evil and see no evil, you will still create evil. So this is from Lindsay Marr, and she's a brilliant, if you want to follow anyone on who knows about air, Lindsay Marr. The red circles are what we cannot change. Nothing, ventilation, disinfection, filtration cannot stop that risk, that close space risk, right? Still get you, but ventilation will reduce far afield risk, disinfection will reduce far afield risk, and filtration will. But it depends on kit, money, big an area, sockets, lots of things. So, okay, we're going back. That was the question that we started with, and I would argue that IPC in care settings is unachievable without indoor air quality and other airborne precautions. And to go back to Adam Grant, the answer is not to accept defeat, it's to find new avenues for influence, and I would add, and tolerable control measures. Thank you for your attention.
If you take nothing else away today, well, hopefully, it won't literally be sniff, swallow. We had some pretty disgusting conversations when we planned this presentation, believe me, but I hope you enjoyed that. And it is really about acknowledging things move on. Evonne is absolutely right. We are not dealing with March 2020 and the evolution presentation of the novel Wuhan coronavirus now. We are in a very different place. If we want to prevent long COVID, we have to prevent the transmission of SARS-CoV-2. We have too many healthcare workers off, unable to work with long COVID. It's going to have a huge impact nationally with the numbers of people with long COVID on economic prosperity and family life and the impact on that. And thinking about children, it goes back to my point about what is the role of infection prevention and control? Are we talking about technical skills in a hospital? Are we talking about the impact of the prevention of infection more widely in the community, including in schools? And one of the best things that I had the opportunity to do during the pandemic, just reflecting, I've reflected on this quite a bit, was actually being able to work with other professionals. So hearing firsthand from the speech and language therapists about the impact on their members, their staff who were going into schools and the transmission of infection. The impact on paramedics who described working in a tin can for 12 to 14 hours a day with no ventilation and patients with COVID in a confined space. Of working with medics and nurses where patients were afraid to get close to staff even though they desperately needed help because they didn't want to give the staff the infection. The patients knew how the infection was spreading. So there is so much learning that we can do. So now really is that opportunity to have that open debate and discussion. And I hope that as a profession and as a country, as a United Kingdom, we can do that.